I'm Michael Lincoff. I'm an interventional cardiologist at the Cleveland Clinic and a clinical trialist.
My name is Jorge Plutzky. I'm a cardiologist. I direct preventive cardiology at the Brigham and Women's Hospital.
So you and I are both cardiologists, but we're deeply involved both in practice and in our research in the so-called cardiometabolic field. So why are we talking about diabetes?
It's a good and fundamental question. The fact is, we've known for a very long time that the presence of diabetes significantly increases cardiovascular risk. It's just been a very long time we've struggled with, what's been referred to as the glucose paradox, that lowering glucose didn't improve cardiovascular outcomes. So on one hand, you were increasing risk. On the other hand, as you treated diabetes, you weren't decreasing that cardiovascular risk. And that's completely changed. It's really a very exciting time to be practicing because we've had the advent of two classes of medications, the SGLT2 inhibitors in our focus today, the GLP-1 receptor agonists that have completely upended that, with very striking demonstration of cardiovascular benefit, as we'll get into. We had initially evidence that argued that just the presence of diabetes without any other cardiovascular history conferred the same risk as someone who had a prior heart attack. We've moved away from that, but the evidence of that degree of risk equivalency, but the fact is the presence of diabetes does mean a 2 to 4-fold increase in cardiovascular adverse outcomes, whether it's heart attack, stroke, myocardial infarction, the need for coronary intervention. So the presence of diabetes is really quite a pervasive effect on the entire vasculature, increasing atherosclerosis and cardiovascular risk across the board. So I think those initial findings really are helpful for the clinician, are still in the guidelines to some extent, that when you see diabetes, you need to be thinking about cardiovascular risk, even if a patient has not yet had an event. Patients often go a long time without their diabetes even being diagnosed. We're thinking more about conditions like prediabetes and the risk associated with that. And so it's an incredibly important issue. And as I like to stress to my colleagues and our trainees, that these are cardiovascular outcomes. These are cardiovascular events. And so we have to understand the disease of diabetes and continue our understanding of the cardiovascular disease and understand therapies that improve cardiovascular outcomes, whether it's, heart failure or MI, stroke, need for revascularization, cardiovascular death, and the like. And now we're into a new era that of agents that actually do that. We really have to leave behind where we used to shrug our shoulders and say, yeah, but treating diabetes doesn't improve outcomes, so I'm not going to do that. I think now we have, clear-cut evidence, not just of the risk of diabetes, but how we can improve outcomes by treating diabetes.